situations. Obviously, this is a little bit of a different type of a situation, right? People are alive.
Yes.
They're driving a motor vehicle, right?
Yes.
Presumably.
Or sleeping in one.
Right, I suppose. And here again, there were 2,345 DUI cases, right?
Yes.
The average level was 9.59, right?
Yes.
And the median level was 5.3. So 50% above 5.3, 50% below.
Correct.
Nevertheless, they were all arrested for DUI, right?
Well, again, as I mentioned, other drugs may be present. So this is just looking at fentanyl.
And so what we're really doing is we're trying to isolate and create some form of a comparison of Mr. Floyd's fentanyl levels and his norfentanyl levels to some sample of population, right?
Correct.
One sample of population we know is alive, right? Because they're driving a car. And the other sample, we have no frame of reference. Did they die from fentanyl overdose or did they die from some other reason? We have no context.
That's correct. All we know is they're deceased.
In terms of when we look at the ratio of fentanyl levels between 9 and 13 nanograms, right? Of the 19,185 post-mortem cases, 3,088 of those cases had a similar fentanyl concentration to Mr. Floyd, right?
Yes.
Again, of the 3,088 cases within that range, we have no frame of reference or no context as to what percentage of those people died from fentanyl overdose versus some other cause or manner of death.
That is true. The only thing we have is a similar concentration.
All right. And so statistically kind of speaking, it's fair to say that some of the 3,088 people in that category died of fentanyl overdose.
Yes.
And some percentage died of some other cause.
Yes.
And again, in terms of the amphetamine, the methamphetamine and the amphetamine, methamphetamine and fentanyl, do you find that to be an unusual mixture of controlled substances?
So I'm not very familiar with what combinations are being seen with street drugs. So we see a variety of controlled substances. We tend to see fentanyl more with cocaine or heroin than with methamphetamine, but that's just what I see. But I can't speak to what is regionally being observed.
Have you heard of the phrase goofball or speedball?
I've heard of speedball, yes.
Okay, but not so. Speedball usually being like a fentanyl, an opiate, and cocaine, right?
Yeah, it used to be heroin and cocaine.
Heroin and cocaine. I'm sorry, and but you've never heard the term goofball.
No.
Okay. Now, in again this particular case, your lab also tested the pills that were found in the squad car as well as in the Mercedes-Benz, right?
Our crime lab did that, yes.
And you've reviewed those?
I have not.
Okay. But similar to fentanyl and norfentanyl, you've got methamphetamines, which is the active ingredient, right?
Yes.
And amphetamines, which is the metabolite, right?
In a tablet, are you saying?
No, in Mr. Floyd's blood sample.
Yes, there was methamphetamine.
Right. And just generally speaking, methamphetamine is the active drug, and amphetamine is the metabolite of that drug.
It's a metabolite, but it's also active.
Okay. So, meaning it's, what do you mean it's also active?
I mean, it's an active metabolite. It also exerts effects.
So a person would have an effect from both of those substances,
Correct.
meaning an intoxicating effect,
Not necessarily.
but some effect.
Some effect.
Relevant to the DUI population, Mr. Floyd's amphetamine and methamphetamine ratio was on the low side, right?
So we didn't look at the ratio of methamphetamine to amphetamine with Mr. Floyd because it was below the reporting limit. It's not on the report. We didn't report it.
Okay. So you can't compare the ratio, but his methamphetamine level was on the low side.
Compared to the DUI population, yes.
And in comparison to the DUI population, as well as the postmortem cases, again, there may have been other drugs, as you say, on board,
Yes.
right? Okay. I have no further questions, Your Honor.
Redirect.
Dr. Eisenschmidt, you were asked some questions about your lab, NMS, and the testing that was performed in conjunction with accreditation standards. Do you remember those questions?
Yes.
You were asked by the medical examiner's office to perform the testing in this case. Is that right?
Correct.
And NMS performed the testing that was requested. Is that
Yes.
right? And did NMS follow all the standard operating procedures when it came to that testing?
We did.
You didn't report anything in your final report that was below your reporting limit, correct?
No.
But you maintain that data in connection with your standard procedures. Is that right?
Yes. And the result, the data shows what we found.
And why do you do that?
Excuse me?
Why do you keep that data?
Because we keep that in a normal course of business.
And is it important to have a record of the testing you did and the things that you went through to achieve your results?
Absolutely.
You were also asked some questions about the methamphetamine level that Mr. Floyd had in his system. You indicated that it was a low level, that 19 nanograms per milliliter, correct?
Yes.
And it was so low, in fact, that you wouldn't expect to feel an intoxicating effect from that level, would you?
I would not.
And in fact, so low that as part of your lab procedures, you'd want to rule out that it's not just a contaminant. That's how low it was, right?
I wouldn't say that. I mean, it's real. It's there, and it was confirmed.
And it was confirmed, part of that confirmation process was that the amphetamine at least supported that it was not just a contaminant. Is that right?
That's true.
But either way, Mr. Floyd's methamphetamine levels were lower than 94% of the driving under the influence population when it comes to methamphetamine. Is that
Yes.
right? You were also asked some questions about the fentanyl levels in this case. Obviously, depending, as you described earlier, depending on an individual's tolerance, a level of 11 nanograms per milliliter could have a different effect on a different person, on different people, depending on their level of tolerance. Is that right?
Yes.
And in your experience with respect to recent or acute fentanyl use, there are a number of cases where you would expect to see no norfentanyl. Is that right?
So yes, we do observe that in cases where we know something's acute, let's say with somebody that dies with a syringe in their arm or something like that.
And if somebody dies with a syringe in their arm, you would expect there to be little to no norfentanyl. Is that right?
Correct.
And why is that?
Because it's a very acute amount. It doesn't mean you could never find it because there could be previous fentanyl use, but that's just not our general observation in that kind of situation.
And in that way, the ratio becomes important. Is that right?
Correct.
And why is the ratio important?
Because that basically documents how acute the fentanyl was relative to its being broken down to fentanyl, or fentanyl, excuse me.
And so Mr. Floyd's ratio of 1.96, 11 nanograms per milliliter of fentanyl to 5.6 nanograms per milliliter of norfentanyl, supports that there was survival time after the ingestion of fentanyl. Is that right?
Sustained.
What does that ratio show you?
It shows two things, that there was survival time from an earlier dose, or there could be an additional dose on top of previous doses.
And again, the ratio is consistent and lower than the average ratio that you see for driving under the influence cases with fentanyl on board. Is that right? What does that show you compared to the driving population?
It just delineates the difference between a population where, a postmortem population where fentanyl is more likely to be acute than in a driving population where it's more likely to be chronic.
And in terms of the ratio, was Mr. Floyd's ratio more similar to the driving population where people were alive, or more similar to the postmortem population where people were dead?
It was more similar to the DUI population.
Nothing further.
Any further?
How can you answer that question when we don't know the context of how people actually died?
Because we still looked at a large number of data within that population.
So you have no frame of reference, though, in terms of what did the person actually die from? I mean, what if of the 19,185 postmortem cases, 19,184 of them were gunshots?
That's not really a possibility, but
I have nothing further.
All right, thank you. Can you step down? Members of the jury, our next witness, we are going to try and fit in. I appreciate your patience and staying till 5:15 if possible, because the witness has a flight out tonight, and so we're trying to finish it tonight. Mr. Blackwell.
Thank you, Your Honor. The state will call Dr. William Smock.
Do you swear or affirm under penalty of perjury that the testimony you're about to give will be the truth and nothing but the truth?
I do, sir. Thank you.
And if you could remove your mask.
Thank you.
And let's start off with having you state and spell your full name.
Dr. Bill Smock, Billsmock.
May I proceed, Your Honor?
You may.
Good afternoon, Dr. Smock.
Good afternoon, sir.
Can we start with your telling us what is your area of specialization?
I'm an emergency medicine physician with specialized training in forensic medicine.
And would you please tell us what is forensic medicine?
Yes, forensic medicine is legal medicine, taking medicine usually practiced by the forensic pathologist, but in my case practiced on living patients and applying that to legal situations.
Could you give us a brief overview of your educational background in medicine?
Yes, sir. I obtained a master's degree in anatomy from the University of Louisville School of Medicine. Entered medical school, graduated in 1990 from the University of Louisville. Then completed a 3-year residency in emergency medicine at the University of Louisville. Then completed a 1-year fellowship in clinical forensic medicine with the Kentucky Medical Examiner's Office.
Have you ever worked in an emergency room in emergency medicine?
Yes, many times, many years.
How many years, doctor?
21 years at the Level 1 Trauma Center at the University of Louisville, and then moonlighting in smaller ERs.
And what is a Level 1 Trauma Center?
The Level 1 Trauma Center is the American College of Surgeons criteria saying that this is the place you want to go when you have major trauma. Gunshot wounds, car wreck, stab wounds, strokes, heart attacks. This is where we have physicians on duty in the ER 24/7 ready to take care of you.
Are there any Level 1 trauma centers in Minnesota that you're aware of?
There was one right here, sir, in Minneapolis.
The Hennepin County Medical Center?
It is, sir.
Do you also teach in the area of emergency medicine?
Yes, sir, I do.
What do you teach and where?
I teach emergency medicine residents, medical students, paramedics, police officers. not only at the University of Louisville, at the Louisville Metro Police Department Police Academy. I trained the paramedics for the Jeffersontown Emergency Medical Service. I also train and teach all over the country in areas relating to strangulation, gunshot wounds, emergency medicine, forensic medicine.
I was going to ask whether you had any special background or expertise in either asphyxial deaths or strangulation.
In both, sir, asphyxial death and so looking at asphyxia, meaning low levels of oxygen in the blood in people that have died, as well as people that did not die.
So you've published or edited several different books.
I've edited 4 textbooks.
We won't read them, but I will show them and call them out. One, Domestic Violence and Non-Fatal Strangulation Assessment.
That is one, sir.
And is this a teaching book?
It is. It's designed to, it's a workbook where you work through case studies looking at the injuries, understanding the injuries, how the injuries occur or don't occur in non-fatal strangulation.
Another one called Forensic Emergency Medicine.
That is correct, sir. That is the second edition of that book.
And a third, larger one, Forensic Medicine, Clinical and Pathological Aspects.
That is correct, sir.
And what is this text for?
That is a text, again, looking at clinical forensic medicine, which is forensic medicine but applied to the patient that is still alive in most cases.
Dr. Smock, have you also, do you also have in your background any work as an assistant medical examiner?
Yes, I do.
What is that, sir?
In Louisville, Kentucky, we started the program through the Kentucky Medical Examiner's Office of providing living forensic medicine consultations. That is providing the same level of evaluation on someone who may have been shot, stabbed, but didn't die in the emergency department in the ICU compared to someone that may have died, given that same level of care. And so that program was started at the Kentucky Medical Examiner's Office back in 1990. And from 1991 through 1997, I was an assistant medical examiner at the Kentucky Medical Examiner's Office, providing those sorts of evaluations and consultations.
So you have a background also then in clinical forensic medicine.
Yes, sir, I do.
Would you tell the jury what that is?
Yes. Clinical forensics is, again, applying the same training that the forensic pathologist gets, from autopsies, the science, the medicine, but applying it to the patient that is in front of you that is still alive. And so what is the difference between someone who has sustained a gunshot wound that's dead versus someone who sustained a gunshot wound that's alive? What did that bullet hit? Did they survive? Did they get to the operating room in time? But the forensics is the same. How do you determine entrance from exit? How far was the gun away from the body when the person was shot? It's that same science, but applied to the living patient.
Dr. Smock, how are you currently employed?
I am the police surgeon for the Louisville Metro Police Department, as well as the medical director for the Training Institute for Strangulation Prevention. I'm also the medical director for the Jeffersontown Emergency Medical Service and a clinical professor of emergency medicine at the University of Louisville.
Could you give the jury some sense of how large the Louisville Police Department is, maybe in comparison to the Minneapolis Police Department?
The Louisville Metro Police Department, we have space for 1,200 sworn officers. We're down to probably a little less than 1,100 officers right now. I think Minneapolis may have 700 to 800. I'm not sure. I think we have a little larger department than Minneapolis.
So would it be fair to describe you as a police surgeon?
That is my title, sir. That is my role. That's my job.
And so what are your duties as a police surgeon?
It varies from day to day. They're multiple. It's the doctor that goes with the SWAT team when the team deploys to make sure that somebody gets hurt, suspect, hostage, officer, that there is a doctor there to take care of them. I advise the police chief on health care policy. I do occupational medicine, looking at the officers when they get hurt, fitness for duty, when can they go back to work, write some prescriptions, antibiotics, Viagra, and most of the time is spent doing living forensic consultations, which means when a detective calls and says, "Doc, we've had a shooting," or internal affairs calls and says, "We've had an officer-involved shooting," I would then go to the scene, to the hospital, wherever that examination needs to be done, and do the assessment head to toe, just like a pathologist would do on someone that is deceased, but doing it on someone that is still alive.
Do you actually do police trainings?
I do, sir.
What kind of trainings?
I get each recruit class. I get 4 hours of training with each recruit class that comes through. 2 hours is spent on the forensic evaluation of gunshot wounds. 2 hours is spent on strangulation, asphyxia, elder abuse, and child abuse.
Have you treated persons with cardiac emergencies?
Cardiac, oh yes, pre-hospital and in the emergency department.
What about dealing with patients who struggle with either methamphetamine or fentanyl addiction?
Very frequently, either again on the scene or in the emergency department.
Are you familiar with the symptoms of overdose for either fentanyl or methamphetamine?
Very familiar, sir.
Can you tell us what Narcan is?
Narcan is an agonist that will block the effects of an opioid on the receptors in the brain. So if you overdose and you've taken too much narcotic and you are not breathing or you're close to going unconscious, if you give this Narcan, we give it intranasally, then that reverses it, displaces the narcotic that's in the brain, and you wake up.
Have you had to make decisions then about administering Narcan for either methamphetamine or fentanyl?
You administer Narcan for fentanyl because it's an opiate, and that's what it reverses. And yes, I've administered Narcan hundreds of times.
So one of the things I'd like to talk with you about with respect to Mr. Floyd is drug tolerance. Is the subject of opioid tolerance something you're familiar with?
Very familiar with, sir.
Can you help us to understand the concept of drug tolerance?
Tolerance is what does the body repeatedly sees a certain drug. The most common we think about is alcohol. That does somebody build up a tolerance, meaning at one time you're a naive drinker, you take one sip, one bottle, whatever, you feel it. But if you are an alcoholic, you feel nothing because that is tolerance. And the same is true for amphetamines and as well as for opiates, for fentanyl. And whether you're talking about Percocet or other opiates, you build up a tolerance, which means it takes more of that drug for your brain to perceive the feeling, the high, whatever it is that you get when you take that medication or drug.
So somebody who doesn't drink might feel the effects of one beer.
Absolutely.
Whereas an alcoholic, it may take, who knows?
It may take multiple beers.
Right. So, doctor, just for the jury, when you made reference to a naive drinker, would you explain what you mean by that? Because
naive means somebody that doesn't drink or doesn't do any sort of drug. Naive means you're totally new.
So, doctor, you've been retained by the state of Minnesota as an expert in this case.
Yes, sir, I have.
Are you being compensated for your time?
Yes, sir, I am, and I hope so. Otherwise, my wife will be very unhappy with me.
Could you tell us then what your hourly rate is?
Yes, the government rate is $300 per hour.
And so the charge for your time is the government rate?
That is correct, sir.
So as part of your work in the case, were you asked to render an opinion regarding the cause of Mr. Floyd's death?
Yes, sir, I was.
Before we get into your opinions, would you tell us what it is you reviewed to give you a foundation for forming opinions?
Oh, I reviewed videotapes, body camera videos, bystander videos, police videos, reviewed medical records, pre-hospital records, statements from witnesses, the autopsy report, autopsy photographs, thousands of pages of documents, sir.
Doctor, before we get to the opinion, there was one thing I meant to ask you and overlooked. As a police surgeon, are you required to maintain board certification in emergency medicine?
No, sir, I am not.
Then are you currently board certified?
No, I'm currently board eligible. I've taken boards on 2 occasions, but since I'm not in the emergency department anymore and it's not required for the police surgeon, I'm no longer board certified.
But you have been in the past.
Oh, yes, sir, on 2 occasions.
So, Doctor, let's talk about your opinions regarding the cause of Mr. Floyd's death.
Yes, sir.
You formulated opinions.
Yes, sir, I did.
Would you tell us what your opinion or opinions are?
Mr. Floyd died from positional asphyxia, which is a fancy way of saying he died because he had no oxygen left in his body.
So what we've been referring to as low oxygen.
Low oxygen is one way, no oxygen. When the body is deprived of oxygen, and in this case from his chest, pressure on his chest and back, he gradually succumbed to lower and lower levels of oxygen until it was gone and he died.
Did you consider other possibilities as causes that you evaluated and dismissed as unlikely?
Absolutely.
Was one of those excited delirium?
Yes, sir, it was.
Would you first tell the ladies and gentlemen of the jury what excited delirium is?
Excited delirium is a physical and psychiatric state where, because of an imbalance in the brain, a patient will exhibit multiple symptoms. Basically, they are hot, their body is revved up, heart rate is up, respiration is up, superhuman strength. They are out of control. Their speech is garbled. It doesn't make sense. They can't answer questions. That's what they call the delirium, someone who is delirious. So I'm very familiar with not only pre-hospital, but in the hospital, the symptoms of excited delirium.
Doctor, let me show you what's marked as Exhibit 921 for identification purposes. So I want to show it to you, and then let me ask you a couple of questions. Is this a demonstrative you created showing the 10 signs of excited delirium?
Yes, sir, it is. Actually, it's from the American College of Emergency Physicians white paper on excited delirium.
And incidentally, before we show this to the jury, or at least I offer it, is excited delirium considered a controversial diagnosis?
Yes, sir, it is.
Why is that?
It's because there are varying opinions as to what causes it, what is it. Forensic pathologists or emergency physicians or other physicians, there isn't 100% agreement on what excited delirium is. But I can tell you, at least in my opinion, I think it is real.
But are there very reputable medical organizations that do not recognize it?
That is correct. The American Medical Association doesn't recognize it. The American Psychiatric Association doesn't recognize it.
So, Your Honor, I offer Exhibit 921 for demonstrative purposes.
Any objection? 921 is received for demonstrative purposes only. Members of the jury will not go back with you on deliberation.
And Your Honor, I happened by accident to manage to scratch on the screen. So if Your Honor could, thank you. So if we could walk through each of these, we'll go through them one by one. And I'd like for you with each one to explain what it is and then explain how it applies to George Floyd. So let's start with the number one, inappropriate clothing, naked or partially clothed. What is the significance of this one? How does it manifest?
When we get a call of a naked man in the street, first thing I'm thinking is excited delirium. Why? Well, would somebody take off their clothes? Well, their body is hot. So in the case of Mr. Floyd, was he appropriately dressed or inappropriately dressed for the weather? And in the case of Mr. Floyd, I think the temperature was in the 70s and he is appropriately dressed. Therefore, this does not apply to Mr. Floyd.
So what about the second one? Attraction to glass, destruction of glass, mirrors, lights on vehicles.
This is another sign that someone with excited delirium, they're attracted to glass, to lights, and mirrors. Sometimes they will kick, punch, try to break the glass, break the mirrors, because for some reason their brain says that is a threat to them. When you watch the video of Mr. Floyd in the store, glass all around him. Was he attracted to any glass on the counter, in the windows? No. So in Mr. Floyd's case, doesn't apply either.
So you eliminated the second one.
Yes, sir, I did.
What about the failure to respond to police presence? What does that mean?
That means when an officer gives you a command to do something, you don't even hear it. You're going on. When we watch the video of the officer asking Mr. Floyd to go to the sidewalk, sit down, does he comply? Absolutely, he complies. Does not apply to Mr. Floyd.
Because you saw him being responsive to the police.
He was responsive, answering appropriate questions, giving appropriate answers.
Number 4, constant or near constant physical activity. What does that mean?
That means these individuals are sped up. Their body is going 90 miles an hour. And in this case, what do we see Mr. Floyd do? He sits down. He's able to sit down. He's not going 90 miles an hour. His activity level isn't constant. So you can cross that one off the
You
list.
saw no evidence of it.
I'm sorry, sir?
I said you saw no evidence of it.
I saw absolutely no evidence of that, sir.
Number 5, not tiring despite heavy exertion.
This again, these people can run a marathon. If you have police officers chasing them, they're outrunning the police. These people go and go and go. Why? Because they're sped up. In this case, did we see Mr. Floyd tire? Absolutely, we saw him tire. We saw him tired to the point where he stopped breathing. So, does it apply in this case? No, it does not.
Number 6, unexpected or unusual strength.
These people are described as having superhuman strength. They're throwing police officers off right and left. Somebody my size is throwing people off right and left. What do we see in this case? Is Mr. Floyd able to throw those police officers off that have him on the ground? No, he's not. So in this case, it does not apply.
Number 7, unaffected by pain.
When we listen to the tapes, do we hear Mr. Floyd complain of pain? Absolutely we do. Pain in his neck, pain in his face, pain in his back. He's complaining of pain. So does this apply to Mr. Floyd? Absolutely not. If Mr. Floyd did not complain of pain, we could add it into the list. But in this case, he's complaining of pain from the time he gets on the ground. Does not apply.
Number 8, very rapid breathing.
These individuals will have a breathing rate 30 to 40 times a minute. Very rapid breathing. When I watched the videotape and counted Mr. Floyd's respirations at different points, it was at one point it was 0, but the other times it's 15 to 20, 22, 23 in that range. By breathing criteria, he does not meet the excited delirium criteria.
What about number 9, excessive heat or hot to touch?
A couple ways to assess this. Did you see evidence of excessive sweating? What did the the ER docs describe when Mr. Floyd presented to the ER? He was cool to touch. When these patients come into the ER, their temperature, you touch them, they are hot. They could be 104, 105, 106, even 107 degrees temperature. Mr. Floyd was cool to touch. Does not apply.
And then excessive sweating, number 10.
Again, because when your body gets hot, when your temperature goes up, what does your body want to do? It wants to sweat to cool you down. So when I watch the video, do I see evidence of sweating on Mr. Floyd? No, it's not there. So again, does not apply.
So Dr. Smock, if we have to have a minimum of 6 of these items, 6 of 10 for excited delirium, how many did you see?
Zip.
So I want to talk with you about another potential cause for death that you may have considered and I think eliminated, which is drug overdose.
Yes, sir.
Are you familiar with the toxicology results in this case?
Yes, sir, I am.
Just to remind us, what were the levels of fentanyl and methamphetamine in Mr. Floyd's blood? And you can check your report or notes if you need
Yes,
to.
I've got the autopsy report here. The fentanyl level was 11. The metabolite of fentanyl, called norfentanyl, was 5.6, and the methamphetamine level was 19. Those are all what's called nanograms per milliliter. That's just the measurement that the lab uses.
Well, focusing on fentanyl, you have lots of experience treating patients suffering from opioid overdoses.
Yes, sir, I do.
Can you explain what fentanyl intoxication looks like and how that might differ from fentanyl overdose?
Yes. The fentanyl, let's kind of work backwards. With fentanyl overdose, because it's a narcotic, in excessive amounts it can kill you because it will cause your respiratory rate to go to nothing. That's how you die with a narcotic overdose. You cease to breathe. With fentanyl toxicity, you're looking at somebody who is high, who is awake, but they're high. So there's a big difference. So how do you differentiate fentanyl intoxication versus fentanyl overdose? What is that patient doing right in front of your eyes? Look at them. Are they awake, alert, talking, breathing normally? Or are they getting sleepy? The respiration's getting less, or are they not breathing at all? That's how you differentiate, just by looking, even without a lab report. Look at what that patient is doing.
So in the case of a fentanyl overdose, are there certain telltale signs of a fentanyl overdose?
Yes, they are. Pupils can be constricted, and they're snoring, their respirations are decreasing, or they're not respiring at all.
Now, bringing this home to George Floyd, when they came to the scene on May 25th, the paramedics, do you recall whether his pupils were constricted or not?
I believe they were dilated.
Do you know what the concept of air hunger is?
Yes, sir, I do.
Would you tell us what that is?
Air hunger, the best application is you are wanting to breathe. For some reason, one example would be if you are drowning. You're going to do everything you can to get to the surface of the water because you want to breathe. Another application that I frequently deal with is someone who has been strangled. When their airway has been cut off and they can't breathe, their body is telling them to breathe, but they can't because of the pressure on their airway. That is hunger. That is the human desire to live, to breathe.
So when George Floyd is saying, please, I can't breathe, is that an example of air hunger?
That is an absolute example of air hunger.
Would you tell the ladies and gentlemen of the jury whether fentanyl overdose causes air hunger?
No, it does not. The only time it could is if you've overdosed, but it's not air hunger because you are going to sleep. You're not hungry at all, you're sleeping. So there is a difference between air hunger, that drive to bring in that air, versus an overdose.
So with an overdose, if it's not air hunger that a fentanyl overdose causes, does fentanyl simply diminish the drive to breathe at all?
At therapeutic levels, no. At an overdose level, yes, it can decrease the drive to breathe if you have too much.
But you're not starving for air.
You're not starving for air.
Doctor, in the case of a fentanyl overdose, you talked about a person going to sleep or snoring even. Before death ensues from a fentanyl overdose, is a coma state reached?
Yes, someone who is asleep, you could say they look like they're in a coma state. They're not moving. So that's what you would see with an overdose.
You've watched the various videos with George Floyd's encounter with the police on May 25th.
Multiple times, sir.
Can you tell the jury, from having looked at those videos, can you tell by looking at that alone whether George Floyd was suffering from a fentanyl overdose?
He is not. I mean, when you watch those videos and we go through them, what is his respiration do? He's breathing. He's talking. He's not snoring. He is saying, please, please get off of me. I want to breathe. I can't breathe. That is not a fentanyl overdose. That is somebody begging to breathe.
And so if a person is suffering from a fentanyl overdose, would you describe that person then as alert?
No, sir. They are not going to be alert. They're going to be sleeping.
Would you describe them as oriented?
No, their brain is going to be in sleep mode or not breathing mode.
And was George Floyd oriented?
Oh, he was. He gave appropriate responses. Name, date of birth.
He knew where he was and what was happening.
He knew exactly where he was, what he was doing, and responding appropriately to the questions that were asked of him.
Have you ever encountered a situation of a fentanyl overdose where a person was in the overdose, displaying air hunger and essentially crying out for their life or crying out in pain?
No, sir.
Now, did you, from your review of the medical records and other data in the case, get some sense of what Mr. Floyd's history was with respect to opioid use?
Yes, sir, I did. When you look at the medical record, Mr. Floyd has been a chronic user, meaning what I saw was for years.
And how would this correlate to the notion of tolerance we talked about at first?
The more you use any drug, alcohol, in this case fentanyl, you build up that tolerance. So it takes more drug to give you that high, to affect your brain. And in this case, we actually had a visit to the emergency department where he took 7 or 8 narcotic pills. They watched him and let him go.
Was there any use of either oxycodone or Percocet that might be relevant to the discussion of tolerance?
Yes, there was when he presented to the emergency department, he said he may have taken Percocet or oxycodone.
So what does that have to do with tolerance to fentanyl?
They both fentanyl and Oxycontin, Percocet, oxycodone, work on the same receptors in the brain, what's called the mu receptor. So they both attach to that and stimulate that receptor. So this is what we call cross tolerance. If they both work on the same receptor, either one is going to give you an effect, depending on the quantity that the brain sees.
In terms of the population of patients you've treated for opioid issues, are you able to generally characterize what the range of the opioid levels has been in living patients?
Yes, I have, sir.
What can you tell us about that?
What I've come to in clinical practice is you don't rely on the level to tell you how much it's impacted a particular patient. You look at that patient, because I've seen patients that could have low level, but I can see patients with fentanyl levels 100, 120, 140, and they're walking and talking. So the level says, yes, it's there, but based upon their prior history of use, chronic use, does that particular level affect them or not?
So how relevant then was the level of the methamphetamine found in Mr. Floyd's blood to your analysis of the cause of death?
Methamphetamine or fentanyl?
Methamphetamine this time.
Methamphetamine. With methamphetamine, it's really a nothing level. It's a level you expect to see with a recreational use of methamphetamine. And clinically, that's a extremely low level.
So I want to switch topics and talk about the cause of death you did find related to asphyxia or low oxygen.
Yes, sir.
Are you familiar with certain myths that exist around the indicators for death by asphyxia or low oxygen?
Yes, sir, I am.
Do you in fact teach your students regarding some of these myths?
Yes, because strangulation is a form of asphyxia. This is part of every class I teach. What are the myths associated with strangulation, with asphyxia, what you see, what you don't see, and why you see something or why you don't see something?
For example, in your teaching of your students, what do you teach them regarding inferences that can be made by the presence or absence of bruising on the body in autopsy?
Bruising. You can be fatally strangled, die of asphyxia, and have no bruising. The presence or absence of a bruise on a human body is dependent upon multiple different variables. How much pressure is applied? How is that pressure is applied? How frequently is that pressure applied? And the example that I like to use is you can have someone put your bicep and forearm on either side of your neck and squeeze, render you unconscious, even kill you, and you will never ever see a bruise on the neck. And the reason is you're applying a broad surface area, bicep and forearm, to a broad surface area, which is different if I were to take, say, this lanyard, put it around somebody's neck and pull tight. I'm putting same amount of pressure, but in a smaller area. And I would expect to see a ligature mark or something. So there are lots of variables that will dictate whether you have a bruise or you don't. Condition of health, if you have any medications that cause you to bruise easy, aspirin, other medications. So you can be, that's this myth that you have to have bruises to prove strangulation. No, you don't. You can be strangled to death and have no bruises. So that's one of the big myths.
Dr. Smock, can you tell us what a petechial hemorrhage is?
Yes, petechial hemorrhage. Petechial hemorrhages are ruptured capillaries. When you see them on a patient, they're little red dots. And what petechial hemorrhages come from is rupture of the capillary bed. They're popped. And the way I like to think about a petechial hemorrhage is like it's a little water balloon. And what happens when I put too much water into a balloon? It pops. What happens if I put too much blood into a capillary? It pops.
So what does the presence or absence of petechial hemorrhages tell us about whether a person did or did not die of asphyxia or low oxygen?
It tells us nothing, because in order to create that ruptured capillary, there are two physiologic things that have to occur in the human body. One, I have to have the venous return, in the case of the neck, the jugular vein blocked. And how does that happen? Well, I'm putting pressure on the neck. The second thing that has to happen is I have to have blood still being pumped into the area of the body, that capillary bed. So if both those two criteria aren't met, blockage of a vein with blood continuing to be pumped in, I will never ever get a petechial hemorrhage. So you can be fatally strangled and not have petechial hemorrhage, because if those two physiologic criteria aren't met, it will never happen.
So, Doctor, I want to show you a few of the video clips as relates to your conclusion that Mr. Floyd passed away from asphyxia or low oxygen. So I want to play the clip and then tell me how it was significant to your decision making. So if we could pull up Exhibit 127, already in evidence, Brett, at 2021. Yes, stopping at 2021. I'm sorry, Brett. Starting at the beginning.
On the ground. Yeah, on the ground. On the ground. Right. You got your restraint? Tobble? Okay. I'll grab that. Get him. Jesus Christ. I can't breathe. Thank you. I can't breathe. Stop moving. Mama. Yeah, Mama. Mama. One of the front couches. Mama. On my right side bag. Mama. You're under arrest, guy. All right. Oh my God. Go to jail. I can't believe this. I can't believe this, man. Mama, I love you. Reese, I love you. You got hobble? To my kids, I love you.
So is this the segment, Dr. Smock, that you listened to and observed?
Yes, this is one of the segments.
Why is this relevant to your assessment?
Well, what's important to the assessment is what's happening over the entire length of the video. In particular, this first section, what we're looking at is listen to Mr. Floyd's voice. He's speaking with full volume. And then I want you, as we go through these different segments, compare what we're hearing now to what we hear later, how his voice changes.
So, go ahead, no, please,
okay.
Finish your answer.
I'm sorry. So I want you to also look at the positioning of the Mr. Floyd. Where is he? Where do we see pressure being applied to his neck, to his upper back, to his lower back? What's also very important is as this progresses, and this is a progression over 4.5, 5 minutes of Mr. Floyd gradually decreasing his ability to survive. And what you'll see, and this is a great, I don't know if I can, does this work, Circle?
It does.
Okay. What I want you to also watch for is what is his right arm doing as this progresses. You will see him pushing against the tire. You'll see his right arm, his elbow, pushing against.
Let's ask another question.
Well, I'd like to know, you circled an area here on this exhibit.
Ask
What
your
is
question.
it? Sorry, Judge.
Go ahead and ask your question.
Yes, I'd like to know, what is it showing us? Why is that significant?
This is very important because it's showing what Mr. Floyd is doing to try and breathe, to get his right side of his chest up off of the pavement so that he can bring in air.
So let's look at another segment. Brett, if we can start at 2021.
I can't breathe.
I can't breathe. My body's so tired this thing.
Relax.
Man, I can't breathe my face. You skin up.
What do you want?
I can't breathe. Please, the knee in my neck. I can't breathe shit.
Bro, get up, get in the car, man.
I will.
Get up, get in the car.
I can't move.
I've been waiting the whole Get up, get in the car.
Mama.
Get up.
Mama. I can't.
Is that the...
All right.
You can't win.
My knee.
You
My
can't
neck.
win, man.
I'm through.
I know you're in
I'm
there.
through.
Listen.
I'm claustrophobic.
My stomach hurts. My neck hurts. Everything hurts. Get some water or something. Please. Please. I can't breathe, officer.
Stop talking. A lot of
They
yelling.
gonna kill me. They gonna kill me, man.
Takes a heck of a lot of oxygen to...
Come on,
His
man.
nose is bleeding. Like, come on now. Look at his nose.
I cannot breathe. I cannot breathe.
His whole nose.
They gonna kill me. They gonna kill me.
How long y'all gotta hold him down?
I
Y'all
can't
don't
breathe.
gotta put y'all right. His nose.
We tried that for 10 minutes.
Why don't we stop there? So, Dr. Smock, as you listened to that segment, that was one that you chose to play for the jury. What was significant about that?
What we're seeing again is, and if you're listening, his voice is now getting gradually weaker as we're going through this. He is telling the officers, I'm about to die. I am through. He's watching his body move, turning his face actually into the pavement to try and get more oxygen in. This is the progression as we go step by step and deeper into lower levels of oxygen in Mr. Floyd's blood. We also have using his elbow to try and leverage his chest up.
So, Doctor, in addition to the subdual and restraint that we see there on the street in the video, was there other evidence, including physical evidence, that supported your conclusion that Mr. Floyd died of low oxygen or asphyxia?
Yes, as I think it'll probably be in the next section as we go through, you will hear his voice get weaker and weaker. You will see his lose facial expression. You will hear him make sounds of trying to breathe as we get closer. He then goes unconscious. You will then see in the next section he has what's called an anoxic seizure. That's a fancy word for his brain is going without oxygen, very low. His legs shake, but you will actually see and you can hear the handcuff shake, and you'll see the body camera shake when he has an anoxic seizure further on down the line.
Were there visible injuries to him as well that you could see, Dr. Smock?
Yes, his left shoulder was ground into the pavement from the pressure from behind. The left side of his face had deep abrasions from his face being pushed into the pavement.
So in the interest of time this afternoon, I won't show the additional video, Dr. Smock, and I want to ask you about a different subject, and that relates to CPR. Could you tell us about the importance of timing with respect to performing CPR?
The sooner we start compressions and ventilations, the higher, the more successful our resuscitation rates will be.
At what point should CPR have been commenced with respect to Mr. Floyd?
Way before it was. As soon as Mr. Floyd is unconscious, he should have been rolled over. We have documentation on the video that the officer says, I can't find a pulse. Why? That's clearly, but when you look at the video, it should have been started way before. Should have been rolled over, checked his respirations. But clearly, when they can't find a pulse, CPR should have been started.
Thank you, Dr. Smock. No further questions.
Mr. Nelson.
Good afternoon, Dr. Smock.
Good afternoon, sir.
Thank you for being here with us this evening. Fair to say you're not a pathologist, correct?
That is correct, sir.
You are not trained in anatomic pathology?
No, it is part of my forensic training, but I'm not and don't consider myself an anatomic pathologist.
And you're not trained in forensic pathology, correct?
I'm trained by a forensic pathologist because that is part of my training. So yes, I am trained in forensic pathology as it applies to the living patient.
And you're not board certified in forensic pathology?
That is correct.
You practice emergency medicine, right?
That is correct, sir.
And you have some experience in, again, as you described, forensics for the living, right?
That is correct, sir.
Do you, in addition to your practice, stay abreast of the medical literature in terms of forensic pathology?
I do get the Journal of Forensic Medicine, sir.
Okay. And how many autopsies have you performed?
Physically performed as what's called the Diener, I don't know, 100. How many autopsies have I attended? Thousands.
Okay. You would agree that methamphetamine and fentanyl, when combined, produces a different result.
They may, depending upon the level and the individual.
So there are variables, but essentially methamphetamine and fentanyl combined is different than a reaction to fentanyl.
That is correct, sir.
All right. And you would agree that in emergency rooms of late, the number of deaths related to the methamphetamine and fentanyl combination have increased.
I can't speak of at late, but it wouldn't surprise me, sir.
All right. And that type of a death, methamphetamine and fentanyl, is a much different type of a death than a simple fentanyl, or not a simple fentanyl, but a fentanyl exclusive death.
Again, depending upon the level, yes, sir.
The level and the individual person, right?
That is correct, sir.
There is no safe level of methamphetamine, right?
No, or there is a safe level of amphetamine, people with ADD.
Right. But in terms of street level, street purchased methamphetamine, there would be no valid medical basis to have that in your system.
That is correct for methamphetamine.
Now, you talked a little bit about the coma state in fentanyl overdoses that you would expect. What's the duration you would expect to see of a coma state in a fentanyl overdose?
That's all going to depend upon how much fentanyl is in that individual system. How quickly do we get Narcan on board? So multiple variables, sir.
Lots of variables. You talk about positional asphyxia, and you've reviewed the autopsy. Did you see any medical autopsy or any physical evidence from the autopsy that can point to Mr. Floyd's airway being obstructed?
No, sir, not in the autopsy.
And while Mr. Floyd initially was on the ground, he was talking, right? As
He was, sir.
And he, at points, raised his head. Agreed?
Yes, sir.
And he, for some period of time, was alert, correct?
Yes, sir, he was.
He was coherent, as you
He was,
described,
sir.
and he was making sense.
Yes, sir.
What is the evidence found at autopsy of significant force that was used to keep him in the prone position?
The evidence was not at autopsy. It is on the videotape, sir.
Okay. You were talking about how Mr. Floyd maintained or stated that he could not breathe while in the prone position.
That is correct, sir.
He stated that before ever being in the prone position as well, correct?
That is correct, sir.
Several times, correct?
That is correct, sir.
At that point, when he stated that he can't breathe and he's in the back seat of the car, there was no one on his back, right?
That is correct, sir.
And do you know whether at that point there's any evidence to suggest that there was a respiratory depressant such as fentanyl on board in his system?
No, sir.
Have you been advised, I mean, I know you prepared a report, but have you been advised that partially ingested pills were located in the back seat of Squad 320 and they contained Mr. Floyd's DNA?
Yes, sir, I was.
And you were advised that those pills were a methamphetamine and fentanyl combination?
That is correct, sir.
People who have their respiration suppressed as a result of fentanyl don't necessarily all the time die, right?
That is correct, sir. We hopefully they don't die.
Treating people in the ER, you have treated people with cardiac diseases?
Yes, sir, I have.
And in terms of your treatment of people with cardiac diseases, have you encountered people who have a combination of methamphetamine and fentanyl?
Yes, sir, I have.
And obviously every single person is unique, correct?
Yes, sir.
And you've experienced people who have cardiac disease, fentanyl, and methamphetamine who pass away.
Yes, sir. Not necessarily from those, but maybe from something else.
But sometimes it could just be from those, right?
Would depend upon the case.
You treat people with COVID at the ER?
I don't, but I've treated police officers with COVID, sir.
Are you aware that people who are in the ICU with COVID are oftentimes held in the prone position?
Yes, sir.
And that actually assists them in their oxygenation, correct?
That is correct, sir.
And they don't necessarily suffer sudden death, right?
That is correct, sir.
Those people may not be moving around very much.
If they're in the ICU, they are probably not moving around very much.
Methamphetamine certainly has an effect on the heart, right?
It can, sir.
I mean, you're aware that methamphetamine can be prescribed, correct?
Amphetamine can be prescribed.
Amphetamine can be prescribed. And one of the side effects of the prescription amphetamine is sudden heart arrhythmias, right?
Depending upon the level, that is certainly it's a rare side effect, but it's certainly possible, sir.
You talked about the pressure that somebody may, the lack of bruising, right, is explained by kind of the surface area of the pressure that's applied, right?
That is one of the variables, sir. That is correct.
And a knee has a relatively small surface area compared to, say, the entirety of the arm, right, that you described?
No, actually, if you think about the size of a knee on a neck, that's comparable, sir.
Okay. And you would agree that in this particular case, when you met with prosecutors several times, right?
Yes, I have, sir.
And you would agree that, generally speaking, Mr. Chauvin did not block both carotid arteries, right?
That is correct, sir.
And he may not have even blocked one of the carotid arteries, right?
That's hard to know.
Okay.
But he could have blocked one of the arteries.
And even if he had, there would be what's called collateral flow, correct?
That is correct, sir.
And so the person, it would be very difficult to render someone unconscious by blocking one of the carotid arteries.
That is correct, sir. As
Generally-
long as they have that collateral flow, meaning blood will go up one of the other arteries in the neck.
And generally speaking, in order to render someone unconscious by blocking the carotid artery, you need to block both carotid arteries, right?
That is correct, sir.
And then when that happens very quickly, right?
That is correct, sir.
Less than 10 seconds.
That is correct.
You've reviewed the videos many times,
I have, sir.
spent a lot of time kind of studying and analyzing the videos.
Yes, sir.
How many hours would you estimate that you had spent analyzing the videos?
10.
Okay. And you were able to see this incident from multiple different camera perspectives, right?
That is correct, sir.
If Mr. Chauvin's knee was placed at the posterior base of the neck, right? That wouldn't have much effect on his diaphragm, would it?
No, sir.
You work with police officers quite regularly,
Every day, sir.
and you've, I'm assuming you said you've gone to SWAT tactical kind of places, right? or to arrests, right?
Yes, sir.
And I assume that you have observed police officers use a prone handcuffing technique.
Yes, sir.
And I assume that you've observed police officers use a prone control technique.
Your Honor, beyond the scope of the witness's expertise, this is causing expertise in the police conduct.
I think it's within his scope of expertise, but it is beyond the scope of direct, so if you could ask non-leading questions.
Sure. So part of your expertise and training with police officers, you train them in terms of how to properly, you train people in terms of positional asphyxia
Yes, sir, I do.
and how to avoid positional asphyxia from occurring.
Yes, it's really not how to cause position, but how does a police officer avoid causing positional asphyxia?
And so based on your experience in training police officers and your experience accompanying police officers to various arrest locations, you have observed police officers use a prone handcuffing technique.
Yes, I have for short periods of time, sir.
And you've observed them place their knee in the posterior or the base of the neck, right?
Yes, again, for short periods of time, sir.
And it obviously depends on every circumstance and situation, right?
I don't understand your question, sir.
I'll withdraw it. Was there bruising on Mr. Floyd's back that you were aware of?
No, sir, there was not.
Bruising in his neck,
No, sir.
either above the skin or below the skin?
No, sir, there was not.
There's unquestionable evidence that Mr. Floyd had cardiovascular disease, correct?
That is correct, sir.
You'd agree that the pathologist who performed the autopsy found a 90% blockage of the right coronary artery?
Yes, sir.
In your experience as an emergency room physician, you could refer someone to have a procedure to open that up, right?
If they are exhibiting signs of a heart attack or cardiac ischemia, meaning they're not getting oxygen to that part of the heart.
And that's called a stent.
That is correct, sir.
The purpose of that is to actually increase or improve the blood flow through the arteries, right?
That is correct, sir.
Because when you have a blocked vessel, that can lead to a heart attack, right?
If it is blocked, that is correct, sir. Completely blocked.
Lead to a cardiac event, right?
If it's completely blocked, that is correct, sir.
And when it's not completely blocked, it forces the heart to work harder.
Yes, sir.
Oftentimes, people go through substantial risks of heart surgery to have that fixed, right?
To have
A partial blockage fixed.
that is correct, sir.
You've reviewed all of his previous medical records that were made available to you, Mr. Floyd's, that is,
Yes, sir, I have.
and high blood pressure from these hospital admissions was noted, correct?
That is correct, sir.
There's no dispute that methamphetamine was in his system at the time of this incident?
The time was at, yes, he had a very low level, sir.
Methamphetamine increases the heart rate,
It can, sir.
so again, it increases the demand on the heart, right?
Absolutely can, sir.
If you had, well, I'll strike that. You were aware that Mr. Floyd had engaged in a struggle with police before he was placed in the prone position, right?
Yes, sir, we did.
That type of physical exertion also puts a certain demand on the heart, right?
It can, sir.
When you observed that struggle, you could observe his vein pulsing?
No, sir, I did not.
That kind of physical exertion of struggling with a couple of police officers, would you say that that's similar to something like what's called a stress test, sort of putting the heart through that physical exertion?
No, sir, that would not be comparable to a stress test.
What is a stress test?
The stress test is when you're put on a treadmill and you're hooked up to monitors, and then you go faster and faster, and then the level of the treadmill can go up and up and up and up.
So similarly, when you're struggling with police officers, your heart rate's going to go up and up and up and up, right?
Your heart rate, but again, that is not a stress test, sir.
Understood.
Okay.
People have had cardiac arrhythmias during struggles with police before?
Yes, sir.
What's the physiological mechanism of a person suffering a brain injury from hypoxia?
When the brain levels of oxygen start going down, certain things will happen. Their level of consciousness will begin to decrease. When they get to the point where their oxygen level is very low, then they will have that anoxic seizure, as we saw with the shaking of the leg and the shaking of the wrists. And then as time goes by, more brain cells die. For every second the brain goes without oxygen, low levels, millions of neurons and cells will die. So what happens when you get to that state? You have brain damage, and then if it's not whatever the cause is, then you die.
So again, brain damage can occur from low oxygen.
That is correct, sir.
When Mr. Floyd was speaking to the police officers, right, as he was in the prone position, do you see any evidence that his brain was injured at that point?
Which part? Because he speaks in full sentences or full voice early, but later on his speech is weaker and weaker until there's no speech. So which window are we talking about?
At any point when he's speaking with police officers, would there be brain damage at that point?
Not while he's speaking, sir.
Can people suffer brain injuries while they're conscious?
Depending upon the mechanism, stroke would be an example. Hitting the head would be another example.
One question I wanted to ask you, you talked a little bit about tolerance, right? And how people can build a tolerance, particularly to opiates, relatively quickly, right?
No, I didn't say quickly.
Okay. Well, people build a tolerance, right?
Yes, sir.
And you've defined, and you're not a toxicologist, correct?
No, sir, I'm not.
Okay. But you have some general familiarity based on your experience as an emergency room doctor, people who are tolerant to particular substances, right?
That is correct, sir.
And when someone stops using a controlled substance for a period of time, that tolerance dissipates. Agreed?
And that is correct, sir.
And with certain types of controlled substances, tolerance dissipates very quickly, specifically fentanyl.
I'm not familiar how quickly it decreases, sir, or increases.
So a person's tolerance is situational, right?
No.
Let me rephrase. Somebody who is tolerant, that tolerance could be built up over an extended period of time. Agreed?
That is correct, sir.
Tolerance, once a person stops using that controlled substance, their tolerance dissipates.
That is correct.
And over some period of
Some
time.
period of time, that is correct, sir.
Could be days, could be weeks, could be months.
In my experience, it's going to be weeks to months, not days, sir.
So if someone's not using a controlled substance for several months, or let's say 2 to 3 months, and then they're going to lose that tolerance. Agreed?
Some part of it, they may, depending upon the substance, sir.
And then if they start using again, right, they're going to start to build that tolerance up to some degree.
That is correct, sir.
And if they had a chronic use for a long period of time, they've decreased their tolerance to some degree. Once they start using again, they're not going to just instantly jump back up to the same tolerance level.
Your Honor, I object to this question as vague.
Overruled on that ground.
Yes, as the tolerance is occurring in the brain, as you see different levels, that tolerance will change over time.
Right. Did you see any evidence in terms of his autopsy or medical records that he had any history of lung disease, Mr. Floyd, that is?
I believe he had history of COVID.
Other than COVID, any other, essentially he would have had healthy lungs by all.
Yeah, I don't recall specifically any lung disease.
But there was evidence of heart disease, right?
That is correct, sir.
When someone is experiencing, again, based in your experience, experiencing an arrhythmia, they would also experience that sensation of a shortness of breath?
It depends on the nature of the arrhythmia.
When someone is experiencing a heart attack, right, because their vessels are blocked and the stress on their heart is increased, would they describe that shortness of breath?
Your Honor, objection. Relevance to George Floyd.
Overruled.
Patients can complain of shortness of breath while they're having a heart attack. That is correct, sir.
You heard the officers ask him if he were on controlled substances?
I believe it was, are you on something?
Right. Is a person at a greater risk for cardiorespiratory effects if they're under the influence of methamphetamine?
It would depend upon the level, sir.
How about a combination of methamphetamine and fentanyl?
Again, it's going to depend upon the level, sir.
Cardiac disease have any relation to methamphetamine use, chronic methamphetamine use?
Yes, sir.
have no further questions, Your Honor.
Mr. Blackwell?
Thank you, Your Honor. Dr. Smock, you were asked quite a few questions about heart disease and high blood pressure. I want to bring this home to Mr. Floyd, and that is whether we're talking about blockage of the artery, high blood pressure, any of it. Was there any evidence that you saw that George Floyd had a heart attack?
There was absolutely no evidence at autopsy of anything that suggested that Mr. Floyd had a heart attack.
And that's whether he had a clogged artery, did he have a heart attack?
That is correct. There's no evidence of a blood clot in any of the arteries. There's no evidence of hemorrhage from a ruptured plaque. There's no evidence that Mr. Floyd had a heart attack.
What about on the autopsy report? Was there any evidence that George Floyd had a heart attack?
No, sir, there was not.
You were asked questions about whether there was a lethal or fatal arrhythmia. Remember those?
I remember those, sir.
If somebody has a fatal arrhythmia that they die from, is that a sudden death?
It is, sir.
As in, I have the arrhythmia, and that's it.
You have the arrhythmia, and then you're unconscious.
Did George Floyd have a sudden death that looked like an arrhythmia?
No, sir. He had a gradual decreased levels of oxygen over the course of minutes. It wasn't sudden. It was gradual because of the pressure being applied to his back and neck.
You were asked questions about Mr. Floyd saying, I can't breathe, when he was in the back of Squad 320. Remember that?
Yes, sir.
Did you hear, or in any of the videos you saw, Mr. Floyd saying, I'm getting choked?
No, sir.
Did you see anything that suggested that in the struggle in the back of the car, that anybody had their hands on his neck or throat?
Not in the car. Mr. Chauvin did put his hands around his neck as he was getting him out of the car, but not in the car, sir.
Right. Obviously, if there is someone getting choked, that's a reason they couldn't breathe.
Yes, sir.
You were asked questions about whether or not the subdual and restraint Mr. Floyd on the ground was a stress test. Can you think of, from any stretch of the imagination, you could refer to being subdued and restrained on the ground for 9 minutes and 29 seconds until the pulse was gone as a stress test?
That objection is argumentative is sustained. Next question.
So, was the subdual and the restraint on the ground a stress test?
No, sir, it was not.
You were asked about whether or not there was any evidence of airway obstruction on autopsy. Was there any evidence of low oxygen on autopsy?
Only his death, sir.
Do you recall Mr. Nelson asking you the question relating to when Mr. Floyd was on the ground? Was he alert and making sense when he was on the ground? Remember that?
Yes, sir, I do.
If somebody is alert and making sense, how could they also be intoxicated?
That's a good question, sir. You can't.
And finally, you were asked questions about the combination of meth and fentanyl, and so whether they make somehow a different kind of a dangerous combination. Just to be clear with the jurors, did you see any evidence that Mr. Floyd died of a meth overdose?
No, sir, he did not.
Did you see any evidence that he died of a fentanyl overdose?
No, sir, he did not.
Did you see any evidence putting them together that he died from that kind of an overdose?
No, sir, he did not.
Thank you. No further questions.
Mr. Mills, anything further?
Did you observe any evidence that Mr. Floyd was choked from the front of his neck?
No, sir.
You would agree that fighting or struggling with police officers puts stress on the heart?
Yes, sir, it could.
There was no other evidence of airway obstruction, correct?
Other than the asphyxia event,
Correct.
other than not being able to breathe, that was the airway obstruction.
In terms of, you were asked on redirect about how could someone who is alert and making sense be intoxicated, do you recall that?
Yes, sir.
People who are tolerant of a particular controlled substance show fewer signs, correct? Of intoxication?
That is correct, sir.
So the more someone is used to taking a particular drug, the fewer signs of impairment they may exhibit. Agree?
That is correct, sir.
And someone who gets arrested for a chronic alcoholic, hypothetically, who gets arrested for driving under the influence, they may not exhibit the same physical symptoms or speech difficulties that a naive drinker may exhibit. Agreed?
Given the same level of alcohol, that is correct, sir.
I have no further questions.
No further questions, John.
Thank you. Thank you, Doctor. You are excused. Have a good flight back. Members of the jury, thank you for your patience in sticking this out. We'll start around 9:15 tomorrow if we can. Thank you. We're adjourned.